So tonight we are going to focus on Chapter 6, which is Managed Care Organizations. So the main objectives that are going to be covered within this presentation is we're going to define the different types of managed care plans. We're going to identify and explain the cost controls utilized by managed care health plans. Explain the contract management and financial incentive tools used by managed care plans. Explain the functions of the National Committee for Quality Assurance and the impact that it has on driving the quality of care. We're going to identify the purpose and goals of the healthcare effectiveness data and information sets, or HEDIS. And we're going to describe the components of Medicare, managed care, and how they impact the Medicare beneficiary. So a quick introduction to managed care. The overall goal of managed care is to provide quality and affordable care to its members, taking into account financial, administrative costs, and services. It's combining a focus on access, cost, and quality. Some of the characteristics include prepaid health plan, its cost control, and managed delivery. It provides access for their members and delivering their appropriate level of care. Managed care plans will achieve savings through contracting, reduced fee schedules through discount rates. So here we have a visual of a managed care contracting providers and all the different areas that consist of that. We have the physicians, the hospitals, home care, inpatient rehab facilities, long-term care, and ambulatory surgical centers. So we have multiple types of managed care plans. There's the health maintenance organizations, or HMOs, preferred provider organizations, or PPOs, point of service, exclusive provider organizations, or integrated delivery systems. So HMOs are voluntary health plans. They provide services in exchange for premiums that are paid. HMOs generally pay for services that are within their network. The goal of an HMO is reducing costs while increasing quality. Premiums for HMOs are generally lower than traditional plans. There are multiple types of HMOs. There's a group model HMO, and this is considered a closed panel where physicians are not permitted to treat other managed care patients outside the plan that they are contracted with. They can provide care to patients that are with plans that are not HMOs. And here we do have a visual of the different HMO plans: group model HMO, staff model HMO, independent practice association, and network model HMOs. So independent practice association, they operate just like an HMO, but not like a group model where they're limited in who they can treat. IPAs are comprised of a group of physicians that get together to form the IPA. The IPA will manage the payments to the group. They will negotiate with payers and leverage the size of the group and the lives they serve. A network model HMO is quite similar to the group model HMO. The HMO will contract with multiple multi-specialty groups to serve their members. A staff model HMO is where the health plan will employ the physician and other healthcare professionals. This is a closed panel. So from that, we're going to jump to preferred provider organizations, or PPOs. And PPOs basically consist of a large group of physicians and hospitals. It provides care as the fees are negotiated in advance. In-network care will be a lower out-of-pocket expense for the member, while out-of-network will come with a larger out-of-pocket cost for the member. With point of service plans, the subscriber must select a physician that will be considered the primary care physician or the PCP. In network, will have a lower cost share for the patient. Out of network will have a higher cost share for the patient. The PCP can be a physician, pediatrician, internist, or OBGYN. The PCPs will basically act as the gatekeeper. The exclusive provider organizations, or EPOs, are similar to PPOs, but patients can only receive care from network providers. It is a closed plan. Integrated delivery system, their services are rendered through a number of affiliated medical facilities. Most IDSs are comprised of multiple facilities. These facilities can consist of physician offices, ambulatory surgical centers, outpatient clinics, and acute care facilities. Within those, there are also different models. There's a group practices without walls, where physicians share in business operation services such as transcription, marketing, and billing. There's the integrated provider organizations, where it houses multiple providers and facilities. Physician hospital organizations, where care is provided through contractual arrangements between a hospital or hospitals and physicians of multiple physician groups. And there's management service organizations, where multiple practices use central administrative and support functions. So one entity that would basically handle the medical records, the release of information, billing, and any other services. So many of the managed care cost controls, they're maintaining quality and contain costs through medical necessity. Where accepted healthcare services that are appropriate in the evaluation and treatment of diseases. Utilization management, which is defined as the evaluation of the medically necessity, appropriateness, and efficient use of the healthcare services. And this is sometimes called the utilization review. And then there's a primary care physician as the gatekeeper. So this gatekeeper is defined as the primary care physician who controls all the patient's access to care. This may revolve around the PCP determining if a referral is warranted. There's also prior authorization. This is considered a cost control measure for managed care organizations. If a provider gets a prior authorization to provide services, it is still not a guarantee of payment by the insurance company. With case management, a collaborative process of assessment, planning, facilitation, and care coordination to meet a patient or patient's family health care needs. It determines what care is considered appropriate, and the goal is to improve quality, provide access to care, while balancing those needs of the patient. Prescription management. A prescription formulary is a form of a cost control measure as well. These formularies will make patients share in the cost of medications. You usually see this done by use of generic versus name brand drugs. The prescription benefit managers are specialty management organization that manage formularies. They negotiate contracts with drug manufacturers and they analyze claims data. So the episode of care payment method, EOC, which is sometimes called a bundled payment. This is where one lump sum of payment is sent to the healthcare providers and covers all services that are provided. Other forms of this episode of care payment can include capitation or global payment. Capitation is a payment made on a per member per month basis, and it's not tied to utilization. Global payment, on the other hand, is a lump sum payment that is distributed among all physicians. It includes the professional and technical component. There's also financial incentives that works for both providers and patients. These incentives can be positive or negative. An example of a negative incentive is a withhold. So this is where part of the payment for a physician is held until they see if they met the cost savings goal for the year. It's usually taken in a capitation environment. Contract management is a very important part of an episode of care payment method. It's a precise management of costs, as contracts need to be designed to cover costs involved in treating the members of the plan. So next we're going to look at an accrediting entity, which is the NCQA. And this is a private, not-for-profit organization that focuses health plans in regards to accreditation, certification, and recognition. So some of the NCQA accreditation programs includes health plan accreditation, disease management, as well as case management. In addition to those, they also provide accreditation for wellness and health promotion, new health plans, and managed behavioral health care organization accreditation. They provide certifications for programs that includes credentials verifications, disease management, health information products, multicultural healthcare, and physician and hospital quality. The NCQA also offers recognition programs. These are programs such as research and industry resources, patient-centered specialty practice recognition, patient-centered medical home, government recognition initiative, the diabetes recognition program, the physician practice connections, and back pain recognition program. So in addition to that, we also have the Healthcare Effectiveness Data and Information Set, otherwise known as HEDIS. This was originally developed by the National Committee for Quality Assurance, along with a group of various health plans and employers. Centers for Medicare and Medicaid Services arguably has the most comprehensive health-related performance measurement database in the world to support its managed care program. It is felt that performance measures alone will contribute to improved outcomes for patients. HEDIS has goals of helping beneficiaries make informed choices. So going back to the Medicare managed care, this came out of the Balanced Budget Act of 1997. And it was basically created the Medicare managed care or the Medicare Part C, it changed to Medicare Plus Choice. So there are 4 plans. There's a coordinated care plans, the Medicare Medical Savings Account, the private fee-for-service, and the religious fraternal benefit. Medicare Advantage, which was established through a competitive bidding process. And the goal of this is to make sure that the Medicare Advantage provides services that meets the members' needs. So the Medical Advantage organization should be constantly striving to gain or retain their market share. A coordinated care plan includes a network of providers that are under a contractual arrangement to deliver the benefit package that is approved by CMS. CCPs also use various mechanisms to help control utilization, such as gatekeepers. So HMOs are generally a more restrictive model than the others offered. An HMO may offer a point of service plan to its beneficiaries that would allow them to utilize services from providers that are out of network. The PPO is a plan that is not licensed as an HMO under state law and has providers under contract to provide services for the covered benefits offered by the plan. So in addition to these, we also have the special needs plans. And these are Medicare Advantage coordinated care plans that meets all the requirements for CMS and offers a Part D plan for prescriptions. There are three categories that are related to targeted populations. There's a chronic conditions, dual eligible, and institutionalized. An institutionalized individual is defined as an individual residing or expected to reside for 90 days or longer within a skilled nursing facility, a nursing facility, or intermediate care facility, or inpatient psychiatric facility. With senior housing facility plans, enrollment is limited to residents of continuing care retirement communities. There's also the medical savings account plans. And this is a plan that combines a high deductible MA plan and a medical savings account that is used to pay for qualified medical expenses for the account holder. Private fee-for-service plans. This plan is also an MA plan that provides a fee-for-service basis without placing the provider at risk. The rates are not subject to vary based on utilization and does not restrict enrollees' choices of providers that are authorized to provide services. They also accept the plan's payment terms and conditions. Then we have the employer group health plans. And this is just basically a group plan that is sponsored by an employer or a labor organization. Last but not least, we have the religious fraternal benefits plan. So this plan as well is an MA plan, and it's offered to a society that is a religious fraternal society. So the enrollment is strictly limited to only those members of the fraternal benefit society. So it will not be offered to anyone outside of that general plan. So to sum this all up, basically the managed care organizations, they do play a huge role in shaping the delivery and the financing of healthcare within the US. They emphasize a lot on cost control, care coordination, and preventative services. And they do have the potential to improve health outcomes while managing expenses. However, there are challenges such as ensuring equitable access, maintaining provider patient satisfaction, as well as balancing cost with quality. And all of these still do remain critical. Hopefully, as healthcare continues to evolve, these managed care organizations can adapt to meet the needs of these diverse populations that we now have, while they continue to foster transparency as well as innovation. With that being done, hopefully they can work towards a system that not only prioritizes the affordability, but the quality of care. So that does conclude the presentation for tonight. Or do we have any questions? Okay, so if there are no questions, I thank you guys for coming out tonight and appreciate you guys taking the time. Thank you and have a good night.